Beth Vogel is going to talk to us now in a more NIMAC-focused way on the results of our needs assessment. So Beth came to the Wadsworth Center. We were very lucky to get her in 2010. She got her master's degree in 2007 from Indiana University. And then right after that, she worked actually in Albany at the Albany Medical Center from 2007 to 2010 when she came to us. And it's kind of interesting that she's been the project director for NIMAC or project manager for NIMAC since about 2014-ish. And while she was in college, she actually volunteered with LUBA at the Pregnancy Risk Network, which is now the Mother to Baby. So she's sort of come full circle. So I will hand it over to Beth. Thanks.
Good morning, everyone. Thank you for joining us bright and early today. And thank you. Mike did a fabulous job giving you the national picture and talking about where things are right now. And so my job here today is to bring you to the NIMAC level and talk about what did we see when we looked at our region and where are the needs and where are the gaps, and then talk about maybe some ways that we can think about trying to bridge those gaps. If you look at your agenda, you'll see that a lot of the things I'm talking about, I'll give you this much information about to help you maybe see the big picture or think about it. But we'd really like you to go to the sessions, think about the breakout sessions, and give us input. We have information from surveys and from data about what we saw as these are where there's needs in genetics. But we want to hear from you today and at this meeting. What do you see as the needs? Do you agree with what we saw from that data? And what are your ideas for how we can improve things? So just know that if you see something that I talk about that's interesting to you, look at your agenda, and there will be a session that you can go to and get the full picture and hopefully give your input to. So this diagram is courtesy of Scott Schoen. Wave your hand, Scott. At the NIMAC Advisory Council meeting last year, we were all thinking about how can we work together better. And Scott went back to his room in the wee hours of the night after we all talked about this throughout the day and came up with this diagram that shows how we have, I call it the flower diagram, and the different stakeholders and work groups of NIMAC all fit together. So we have our genetics providers and newborn screening, who are one petal of our flower, our primary care providers, public health, healthcare access and finance, capacity and communications, and then the most important, I won't forget our happy watering can there, which are our consumers, who are helping our flower to grow and working very closely with us. So this has been a big group effort to complete this needs assessment. All of the work groups contributed, all of the stakeholders involved contributed, so this is my opportunity to thank all of you as well, and we've been very busy. So first, let's talk about the consumers and what the consumers saw as the needs for genetics. So some of this will sound similar to what you heard from Mike. The consumers said that finding a provider with expertise in a particular condition is important to them and something they see as a gap in genetic services. This is true for the NIMAC region as well as what we heard from the national picture. Cost, distance to get to appointments, appointment wait time, as well as social and emotional support. So next, how do we know? How do we know those are the gaps and that's what the consumers think? The NCC worked on a national survey. 146 consumers from the NIMAC region took that survey. Again, the majority of them, 22%, said that the lack of providers with expertise in a particular condition was a barrier to access of genetic services. 10.5% said cost, 7.6% said availability or wait time for an appointment, and then 6.2% said distance. But that survey included some other questions as well that I thought I would mention now, that 37% of patients in the NIMAC region who took this survey said that they travel over 2 hours for services. I think that's a pretty impressive statistic, right? Over 2 hours. And I tend to think our region has a lot of big cities. So keep that in mind, that even though we have big cities, 30% are traveling 2 hours for services. 4.8% said that they had been offered telemedicine visits, but 63.7% would be willing to receive services by telemedicine. We have 2 sessions in this meeting to talk about telemedicine. So if those pique your interest, make sure, well, one's during the general session, and then we'll also have a breakout to discuss that as well. And then this survey also included a Likert scale and said on rank 1 to 5, what's difficult for you as a consumer for access, and they said the obtaining social and emotional support, as well as getting specialist visits set up. So NIMAC is not that different from the national picture in this area. NIMAC also conducted our own consumer benefits survey, and a lot of the questions were about how much people are paying, and I'll talk about that in a little bit. But we also asked questions about access and said to the people taking the survey, where's the difficulty with access? 184 consumers took this survey, and most of them, again, said long wait lists needed for services is a problem, providers not being in our network, we could not identify providers that we need, it's too expensive to pay for what insurance does not cover, and it's too far to travel. So we're starting to see some themes emerge from these 2 surveys that the underlying issues that we're hearing from our consumers are the same. They want to be able to find the services they need, not have to travel long distances to get those services, and not have to wait a long time for them. And so I think those are things we probably could have guessed, but now we have some data to support that. So next, let's look at our next petal of our flower, the genetics providers and newborn screening. I'll look at those one at a time. So from the genetics provider perspective, what would they say the gaps are? For the genetics providers in the audience, what would you say the gaps are in genetic services? Workforce comes out as one of the number 1 issues. And then we also learned transition, insurance, and then having patient information available in multiple languages. So again, how do we know these are the gaps? We looked at publicly available information. We looked at the NCC provider survey, and our evaluators, Melissa and Amanda, they spent a lot of time looking at the NIMAC specific data from that overall national survey. We have some newborn screening timeliness data collection, as well as a discussion that happened at a newborn screening symposium that was a regional meeting in 2015. So there's between 400 and 500 genetic counselors in the NIMAC region, but 53% of them reside in New York and Pennsylvania. And so this is as of when we were able to get this and what's publicly available, but at that time, West Virginia had 2 genetic counselors. So that, just so that we can start to think about that we have a lot of specialists, we have a lot of genetics providers in our region, but the distribution may be an issue. The NCC provider survey, so 90 genetic counselors from the NIMAC region responded to the survey, 33 geneticists, 20 metabolic dietitians, genetic nurses, nurse practitioners, and physician's assistants. So this survey actually, I think, has some good news that 40 of the people who responded had been in the field for 0 to 5 years. So we have some new people coming into the field, but we also have 60% with more than 10 years of experience. And then 18 individuals said that they were 0 to 5 years until they retire. So we're looking at the overall picture that we've got some new people coming into the field, but we also have people who are planning to retire soon that may leave gaps. I think looking at how much of an impact those people retiring and those geneticists maybe leaving has on the system depends on where they're located, because we have some areas of the region where there might only be 1 geneticist covering a huge region. And so if they leave and retire, that's a big issue for that area. So that's something for us to continue looking at as well from the NIMAC perspective is we got this information from the NCC survey, but where are those providers and what will the impact be? A question was also asked about job vacancies. So 53 people from the NIMAC region who took this survey said that they had a job vacancy at their institution in genetics. So many job openings for genetic counselors, for MD geneticists, some jobs for care coordinators, open fellowship and residency positions, as well as positions for genetic nurses and metabolic dietitians. So we know that the positions are out there and that there are openings, and that shows that there is a need in those institutions for more providers. Geneticists and respondents to this survey were also asked, what do you think the unmet needs are in genetics? 38% said that there's a need for more information and for transition information from pediatric to adult care and doing better with that. So we will talk about transition during one of our breakout sessions. Navigating insurance came out as a big issue. We'll talk about reimbursement for genetic services. And then information about genetic conditions in languages other than English, which actually for us as a NIMAC team was really valuable information and feedback to have from the providers in our region that's something that they're looking for because that's something that we can help with. So now let's take a step and look at newborn screening system. Timeliness is an issue, as well as support for adding conditions, both from the clinical and the laboratory perspective. So this is some data that is borrowed from Marcy Sontag, who's the Newborn Screening Technical Assistance and Evaluation Program leadership. And Marcy put this together for us. The purple is the NIMAC data, and then the red is the national. And these are the percent of samples that are collected prior to 48 hours of age. So you can see that across the NIMAC region, less samples are being collected prior to 48 hours of age in babies being born in our region than happening nationally. So this shows us that we have a need to work on this issue. So next we have the percent of specimens that were received by the lab within 48 hours of collection. And again, you can see across the NIMAC region, less samples are being received by the lab within 48 hours than what's happening nationally. So here we've identified a need and a place that we can work to improve in the newborn screening system across the region. So let's talk a little bit about the meeting that we had. I see several faces of those who attended that meeting. We had a meeting to talk about MPS I and Pompe disease, two of the conditions that have been recommended to, and have been added to the recommended uniform screening panel. And we talked about what are the barriers to implementing screening for these conditions, and what did people see as the issues. So first we talked with and focused on the laboratory issues and then the clinical issues. The laboratory said, we see that molecular testing is really important for these new conditions and really gives valuable information, but that implementing that and the new personnel needed for that and the time and interpretation of the data. We just heard from Mike about all of the variants that you're likely to find doing that. All of the issues that will arise from adding molecular testing are a struggle for programs. IT infrastructure is also something people identified as a struggle, as well as the space and equipment to add new tests, and then regulatory issues. So these things are strong considerations for labs as they're thinking about whether or not to add a new test and sometimes having pressure to add a new test because it's been added to the panel. So next we talked about the clinical issues. Again, I just talked about the workforce issues. You heard about those from Mike too. People were worried. These patients take a lot of time. There's a lot of care coordination that needs to happen. We don't have the staff to do that. Those came out again and again as issues. Reimbursement issues, whether it's for molecular testing or for treatment. The information that's needed for diagnosis, management, and treatment and long-term follow-up. So if you have a patient who comes in and you don't know how to interpret their test result because there's not enough information available, that's a struggle for you and for the family. So having the infrastructure to collect information and hopefully build and have that available is something that's really important and that people saw as a current gap in what we're able to do. Education also across the entire system, from the primary care providers, the hospitals, the patients and families, was a discussion point as well. And at the very end of this meeting, we'll have a whole breakout session talking about education and newborn screening and where the needs are. All right, so let's move on to our next pedal, healthcare access and finance. So what are the gaps from that perspective? Well, I guess there's a lot of gaps from that perspective, but high out-of-pocket costs and coverage of specific services, including non-prescription medications, modified and prescribed medical foods, and equipment to support activities of daily living are what we got back from our consumers as gaps for financing their health care. So a consumer benefits survey was conducted by NIMAC, as well as we just completed analysis on a PKU medical food survey. The PKU medical food survey results will be discussed at a breakout session specifically focused on going through those and discussing that in detail. So if you're interested to hear more about that beyond what I say, please attend that session. So the consumer benefits survey, these were consumers and people with genetic conditions or parents of children with genetic conditions in the NIMAC region. 60% have premium costs over $1,000. 67% had deductibles up to $2,500. For this one, for me, 20% paid over $5,000 for their child's health care beyond deductibles. It's a lot. So that's 1 in 5 parents of a child with a genetic condition in our region are paying over $5,000 a year beyond their deductible for their child's health care. The NIMAC Consumer Benefits Survey led us to do a survey of medical foods. So we saw that come out as an issue that we were hearing the consumers say was a particular specific service that was hard for them to access. Some high-level stats from that, of those using low-protein foods, more than half said the amount that they received is not satisfying their needs. So they really need more to be in good metabolic control. For 64%, insurance was not covering any portion of low-protein foods. And 133 people with PKU took this survey. So I think this is really something that is an area we need to focus on and think about more, and some of those discussions are happening nationally as well, and we'll discuss them in detail later. Okay, so I'm moving kind of quick here, but I want to make sure I get through every one of these. So let's talk about primary care. What are the needs? Education and awareness, helping with confidence talking to families about genetics, knowing when to refer to genetics, and assistance with offering genetic testing. So how do we know these are the gaps? We conducted a genetics and hearing loss survey, as well as obtained some data on Fragile X and the time of testing. Both of those will also be breakout sessions during the meeting. So these stats are primary care providers, who also included physician's assistants and nurse practitioners, pediatricians, and family practice providers, who were asked questions about referring individuals with hearing loss to genetics. 41% of respondents did not refer families to genetics. 47% were uninformed about hearing loss genetics. 55% were not confident about the genetic causes of hearing loss. This is the one that really, 44% never consulted genetic professionals. 37% were not confident about the importance of a genetic referral. So we learned a lot about genetics and hearing loss from this survey, but we also learned a lot about the gaps in education that need to happen. The Fragile X data. So we were fortunate enough that LabCorp shared data with us. We wanted to know, when is Fragile X testing being ordered in individuals across our region? The reason for that is twofold. First, Fragile X testing may be one of the first tests that's done in somebody with intellectual disability or developmental delay if they're trying to identify the genetic cause. So even though we don't know whether these individuals ended up having Fragile X, we didn't get that piece of data from LabCorp, it gives us information about when that workup is happening. So for males, the average was 9.6 years, and most of them were under 12 when the testing was ordered. For females, average age was about 30, and almost all of the tests were ordered for females over 18 years of age. So from this, we can also see that that referral to genetics for children with intellectual disability or developmental delay may be happening later than the ideal time. Okay. Our next pedal is public health. We have a public health work group who did a lot of needs assessment activity. And really, a theme came out of that the biggest gap is quality improvement. Working with an expert from the Heartland region, we conducted a genetic system analysis and assessment. So a long survey went to each of the health departments across the NIMAC region, and they completed and answered questions for us about what types of things they're doing related to genetics and newborn screening. And we got back a very nice report from Ann Chow, who's an expert, and she said that workforce training sufficiency, performance reporting and improvement, and using documentation of data sources, as well as clinical process and quality improvement, specifically patient rating of provider-patient interaction, are areas that NIMAC could do better. So I will say, across all of this, there were areas that we were doing well too, but I'm talking about the gaps. So look at the posters if you want to feel a little better, because there were things that we're doing well. But for me, there was a theme amongst these things, and that was quality improvement. If you look at each of these, workforce training, documenting data sources and performance reporting, clinical process and quality improvement, the theme here is quality improvement activities, which works out well that a focus of, as Mike said, of what we'll be working on in the future involves quality improvement. Next, capacity and communications. We have a work group in NIMAC who focuses on getting information out to individuals in our region, to healthcare providers, to patients and families. And this group works really hard and has made great strides, I can say with confidence. But we found a real struggle in reaching primary care providers with education information about genetics. We sent an email to pediatricians through the American Academy of Pediatrics about timeliness in newborn screening. This went to 10,000 pediatricians across the NIMAC region that are members of the American Academy of Pediatrics. 13% of them opened and looked at our email, which actually we thought was not too bad, but it shows that we're still missing a lot of people that we may be able to provide education to about newborn screening, and how do we get that information to them at the time that they need it. We also did a mailing to pediatricians through that same mailing list. We mailed a postcard about Fragile X syndrome. There's actually some of those postcards up on the NIMAC table in the Edinburgh Hall if you're curious to see what that looks like. So that was also mailed to 10,000 pediatricians. It's much harder to evaluate the impact of a mailing. We don't know, once they got that postcard, did they look at it and pin it up in their office? Did it go in the garbage? I hope not, but we don't know. We do know that we got some additional web traffic related to that, so hopefully they were looking at that postcard, but it's hard to say. We did a social media campaign on Facebook, and this actually turned out to be a fabulous way for us to engage with patients and families. We had phenomenal numbers of patients and families who looked at and saw NIMAC ads, educational messages about genetics and newborn screening. We were not as successful with that information getting to healthcare providers and pediatricians specifically as well. So I think this is an area that we're still trying to find our way through, and as education is such a huge component for us going forward, and we saw that there's this big need for it, it'll be something for us to continue working at and finding unique ways to engage with primary care providers. So that's also a question I have for all of you and to think about, is how can we continue to do this and how can we do that well? How do we get them the information at the time that they need it? So this is also borrowed from Scott, but the work that I presented today is not all mine. Our work groups worked really hard on putting surveys together, gathering data, asking questions, analyzing the results. So if we want to go fast, go alone. If we want to go far, go together. And I think we can say that we really went far this year with getting a good look at what the needs are. But next, we really need to think further about how do we start to address these needs. So to increase access to services, we saw that as a need, right? We can connect consumers to services, and we can talk about reimbursement issues. To increase capacity to provide genetic services, we can work on telemedicine and telegenetics. We can think about standardized approaches to providing genetic services, as well as geneticist technical assistance. For those of you in the audience who are not registered for the dinner tonight, we do have some space left in that dinner. we will be talking about a study that was done looking at genetic counseling assistance. And I think it'll be really interesting. So if you are not registered for that, see Bonnie. If you don't remember if you're registered for that, look at your name tag. If you have a bright yellow dot, you are registered. Okay. So what's another way that we can bridge the gap? We need to develop and track quality improvement measures. Doing that by partnering with public health, looking at how can we measure quality improvement for transition, as well as improving care coordination. Leveraging collaborations is really important. There's no way that any one group can tackle all of these issues. The newborn screening programs across the region have always had a strong collaboration, working together, and we need to continue that. Working with consumers for advocacy and genomic education is really important, and we have we'll be hearing about that later as well during a breakout session. Collaborating with primary care providers, how do they want to receive the information? How can we integrate family history into primary care? So I've given you a lot of information in a short amount of time, but rest assured that you will hear a lot more about these topics, both in the meeting and also at the posters, and I'll also be around and I'm happy to discuss further, and I think we have some time for questions. So thank you all.